We are going to discuss about the approach to young hypertension. So let's discuss about the definition of hypertension first. ACC guideline has told that 130/80 is the cutoff, and ESC guideline has told 140/90 in single setting. But in daytime and nighttime and 24-hour ambulatory blood pressure monitoring are different. Nighttime is lower than the daytime. And now let's discuss about ACC guideline. Normal blood pressure is less than 120 systolic and less than 80 mmHg in diastolic. Elevated blood pressure is called when systolic blood pressure is more than 120 to 129. Stage 1 hypertension when systolic blood pressure is more than 130 to 139 and diastolic 80 to 89. But stage 2 hypertension is called systolic hypertension more than 140 and diastolic BP is more than 90. So here hypertension is defined stage 1 even if more than 130. You can also understand that systolic hypertension can be isolated and isolated diastolic hypertension can be present. And EC guideline is telling that grade 1 hypertension if more than 140 and diastolic more than 90. And now here is another one which is called JNC. JNC classification also saying that if more than 140 systolic blood pressure and more than 90 diastolic blood pressure is called stage 1 hypertension. And hypertension in young, to whom we call young, it is more than 19 years of age and less than 40 years. So if anyone is coming less than 40 years, less equal to 14 years with hypertension, systolic blood pressure more than 140 and diastolic blood pressure more than 90, then we suspect them as a young hypertension patient. We should approach those patients to evaluate the etiology also. Here we have to identify white coat hypertension when there is only elevated blood pressure in the office time, but during home time those patients do not have any hypertension. And another resistant hypertension, which is most commonly present in case of secondary hypertensions also. So resistant hypertension is more than 140/90 mmHg blood pressure even giving the optimal dose of antihypertensive should be in three antihypertensive including one diuretics. There is also certain other definition. Hypertensive urgency when there is blood pressure more than 180/120 without any target organ damage. Without any target organ damage is urgency, and if there is target organ damage then it is called emergency. What are the targets organ? Targets organ can be pulmonary edema, cardiac ischemia like myocardial infarction, or retinopathy, or AKI. And here is another one which is called pseudo hypertension. Pseudo hypertension is falsely elevated BP due to calcification or sclerosis of the arteries. What happens here? When you inflate the cuff, those arteries do not collapse. So there is crotocough sound present even during the inflation of cuff, where the manometer shows more than systolic blood pressure. Those arteries will not be collapsed and the crotocough sounds will be present. So it suggests that the radial pulse remain palpable despite occlusion of the brachial artery by the cuff. This is known as Osler maneuver. Osler maneuver should be done to look for pseudo hypertension. So we have seen about the definition. We have understood that the white coat hypertension may be present. There sometimes the hypertension is present in single setting. So whenever we have doubt that this patient may have normal blood pressure during any time in the day or night, then we have to go for ambulatory blood pressure monitoring. It is done if there is white coat hypertension present, if suspected episodic hypertension is present, patient is coming with normal blood pressure but the patient has symptoms of the hypertension and any other target organ damages. Hypotensive symptoms while taking antihypertensive, we have to check the ambulatory blood pressure to titrate the doses. Evaluation of resistant hypertension when the hypertension is more and when the blood pressure is getting normals. Assessment of nocturnal BP values is very much important. Suspicion of nocturnal hypertension such as sleep apnea, where there is hypertension during the sleep apnea, and daytime hypertension and autonomic dysfunction also. Now introduction to young hypertension. Why young patients have hypertension? we have to understand that the most common cause of hypertension is essential hypertension, but the secondary hypertension, which may be present in the young patient more commonly, can be diagnosed and can be treated. And those secondary hypertension, if treated, then target organ damage, even the hypertension, can be managed completely and cured from the hypertension. So let's discuss about the causes. As I have discussed, the most common cause is essential hypertension, and secondary hypertension is most common due to renal parenchymal disease, renovascular disease like renal artery stenosis, etc. Drugs, endocrine causes, you can check here: thyroid disorder, hypercalcemia, acromegaly, Cushing, aldosteronism, pheochromocytoma, and acromegaly. Obstructive sleep apnea, preeclampsia, eclampsia in case of pregnant female. So we have discussed that there is essential hypertension, which is most common, and secondary hypertension is the other common causes of hypertension in young. So how will we suspect, when we will suspect that patient may have secondary hypertension? First, poor response to therapy. Worsening control of the previously stable hypertension. Patient was initially stable hypertension with medication, but now the hypertension is worsening gradually. And significant hypertensive changes to the target organ damage. Patient has no symptoms of hypertension, but the target organ damages has happened a lot. Then we will suspect the secondary hypertension. Lack of family history. If the family history is present, there is more likely essential hypertension is present. But if the family history is absent, there is chances of secondary hypertension. Onset of hypertension, if very young, less than 20 years, and very old age, more than 50 years, then we should suspect secondary hypertension. Now let's discuss about the some drugs which can cause hypertension. OCB is very commonly used in reproductive age group female, which can cause hypertension. Diet pill like phenyl propanolol, sibutramine, nasal decongestant, which we give sometimes in upper respiratory tract infection, allergic rhinitis, and in epistaxis patient. So phenylephrine, etc. And stimulant drug like amphetamine, cocaine, ecstasy, etc. Immunosuppressive, very common: cyclosporine and steroid very commonly used as immunosuppressive, which can cause increase in BP. Other drugs like NSAID, herbal medicine, etc. Erythropoietin may cause hypertension, so you should check the BP of CKD patient before giving erythropoietin. Anabolic steroid, etc. Most important part is measure the blood pressure accurately and take thorough history and examination. You can grab the cause, or you can check the blood pressure to hyper actually present or not. For checking blood pressure, you have to follow certain steps, and blood pressure should be measured accurately, because the difficulties and the mismeasurement of the blood pressure may lead to inappropriate blood pressure monitoring and ultimately leads to chaos. So step 1 is properly prepare the patient, and step 2, use proper technique for BP measurements. How to prepare the patient? Patient should take rest for 5 minutes in a chair in sitting relaxed position, and patient should not take any caffeine or exercise or smoking for at least 30 minutes before measurement, and remove all clothing covering the cuff, covering the area of the cuff placements. And step 2 is to proper technique for BP measurements. Device should be validated and calibrated regularly, and patient arm should be supported. Position of the middle of the cuff should be at the level of right atrium, and use of the correct size of cuff, and BP cuff should cover almost 80% of the arm. And step 3 is taking proper measurements, and proper measurements by means recording the blood pressure in both arm, using the which arm gives the higher reading, take that reading. And you should measure the blood pressure in 2 occasions by 1 to 2 minute gap. And first you should check the blood pressure by palpatory method and inflate the cuff by 20 to 30 mmg above the auscultatory determination of the systolic blood pressure to look for any systolic gap if present or not. And properly document the BP and record systolic blood pressure and diastolic blood pressure. Once the first cotocough sound is present, then gradually deflate the curve by 2 mmHg in per second, and record for the disappearance of the cotocough sound for the diastolic blood pressure, and average the reading. If you are getting reading in 2 occasion, then average 2 reading and obtained on two occasions. You cannot determine a patient as hypertensive, diagnose a patient as hypertensive in a single occasion if you are getting more than 140/90 bp. So you should take the two measurements, and if you are getting a very high blood pressure like 170/100, then you are much more sure that patient is having hypertension. And now about history taking. What the history we should take first, though, for how many duration the patient is, how much duration patient is known hypertensive, prior treatment of hypertension, what he was taking, and the any history of drug which he was taking or she was taking, symptoms of secondary causes like tachycardia, sweating, and tremor. Those are the autonomic symptoms. Thinning of skin, these are symptoms of Cushing syndrome. And flank pain in case of renal vascular disorder. And other like obstructive sleep apnea patient is having or not, daytime somnolence, loud snoring, erratic sleep, target organ damage present on like headache, transient weakness of blindness in case of retinopathy, loss of visual acuity, chest pain dyspnea, and chest and dyspnea are the symptoms of LVH, and claudication in case of peripheral arterial diseases. Family history of hypertension, premature cardiovascular disease, or familial disease like pheochromocytoma, renal disease, diabetes, and gout, all are the familial history which can cause the secondary hypertension, which can give clue to secondary hypertension etiology. Presence of other risk factors like smoking, diabetes, dyslipidemia, and physical inactivity in sedentary lifestyle, preeclampsia and eclampsia. Dietary history, how much sodium he is taking, processed food is taking or not, alcohol intake, and saturated fat. In physical examination, you should first check about the general appearance, patient's BMI, and body fat composition, and skin lesion, which can give you hint to the secondary hypertension causes. And blood pressure should be measured in all four limbs, as there may be discordant to the upper limb and lower limb, and the both upper limb also. And upper limb blood pressure should be measured in standing and supine position, as there may be presence of postural hypotension or hypertension. Both can be present in secondary hypertension also. And pulses, all peripheral pulses should be checked, radial, radiofemoral delay, and palpable blood vessel wall, as if the stiffness of the blood vessel is present, then atherosclerotic causes like essential hypertension can be caused. Other like periorbital puffiness and pedal edema, which can be present in case of renal parenchymal disease. Neck examination should be done for palpation and auscultation of carotid to look for any atherosclerosis. Thyroid swelling is present or not. Toxic thyroid nodule or goiter may be present, which can present as secondary hypertension. Acanthosis nigricans and skin test should be checked for the dyslipidemia and impedient diabetes mellitus. Apex beat location, diameter, and amplitude, rhythm, and murmur should be checked for any abnormalities of target organ damage or presence of any secondary hypertension etiology. And bronchi and rails should be checked for target organ damage in the lung. Abdominal examination for renal muscles, if present or not, should be checked. Bruit over the aorta and renal artery to look for any atherosclerotic plaque is present or not. Visual disturbance for retinopathy present or not. Focal weakness and confusion for hypertensive encephalopathy. Fundoscopy should be checked to look for hemorrhage, papilledema, cotton spot, and arterial narrowing. We can check and grade this according to Keith-Figner grading. For investigation, this chart is given in the Harrison. For renal parenchymal disease, you should check urine REME, serum urea creatinine, and for renovascular disorder, even in renal parenchymal disorder also, USG KUB to look for any renal vascular disorder also. Endocrine disorder, look for sodium, potassium, calcium, and thyroid. And for metabolic causes like fasting blood glucose, HbA1c, total cholesterol, HDL, LDL cholesterol, and triglyceride to look for dyslipidemia. Even fasting blood glucose metabolic etiology, fasting blood glucose should be checked for metabolic, and even in case of acromegaly, fasting blood glucose may be higher. And other like hematocrit and ECG should be. So certain basic obligatory investigation you should check, but as previously was done, an extensive workup was previously used, but this is not necessary. You have to examine the patient and take the history and do a basic set of investigation, and according to the result, according to the investigation report, you should check for the specialized test for suspicion of particular causes of secondary hypertension. Here are certain etiology, secondary hypertension etiology. For that you have to check for different investigation, and you will get clues for that particular secondary causes of hypertension also. Like in case of coarctation of aorta, in sign and symptom you have to check the blood pressure in the lower limb, which will be and the upper limb, and you will get the difference of more than 20 mmHg, and delay or absent femoral pulses during radiofemoral delay, and you will get a murmur over the aorta or over the chest wall. And you should check by the magnetic MRI and transthoracic echocardiography in children and MRI in adult. You will pick up the diagnosis. And for renal artery stenosis, you should check for serum creatinine concentration. It may be raised, and you can also check for renal artery bruit, and this will be confirmed by the CT angiography or Doppler EVSG or MRI with gadolinium contrast media also. And next, thyroid disorder, you will get the bradycardia if there is hypothyroidism, and in case of hypothyroidism you will get diastolic hypertension. Systolic hypertension will not be present. Systolic hypertension is very much common in case of hyperthyroidism, where you will get tachycardia. Cold and heat intolerance, cold intolerance in case of hypothyroidism, heat in case of hyperthyroidism, constipation in case of hypothyroidism, diarrhea in case of hyperthyroidism. This is not diarrhea, actually this is hyperdefecation. Irregular, heavy and absent menstrual cycle, this can be present in hyper and hypothyroidism both. So you will check for thyroid stimulating hormone TSH, and according to findings or investigation result you will further work up. And in case of hyperaldosteronism, you will get hypokalemia. So there is excess aldosterone which will excrete the potassium through the renal tubule, and it will retain sodium, and retention of sodium will lead to hypertension. So here you can assess the renin and aldosterone level and calculate the aldosterone renin ratio also. By this you can diagnose this hyperaldosteronism. In case of obstructive sleep apnea, patient will give a history apneic event in the during sleep, snoring and daytime sleepiness also, and you will diagnose this patient by polysomnography and sleep study. And sleep apnea clinical score is present, which is done using the pulse oximeter at the night time. Now another two endocrine causes, one is pheochromocytoma. You know the pheochromocytoma is excessive secretion of the noradrenaline and adrenaline, metanephrines actually, and this may cause flushing, headache, level blood pressure and orthostatic hypotension, which I was telling. Orthostatic hypertension is a classical feature for essential hypertension, but orthostatic hypotension may also be present in case of pheochromocytoma. Palpitation, sweating and syncope may be present. So the diagnosis can be done by plasma free metanephrine and 24-hour urine, fractionated metanephrine. You can also look for adrenal gland by imaging, USG whole abdomen or CCT adrenal protocol. And in case of Cushing syndrome, you will check for buffalo hump, central obesity, moon phases, stria present or not, facial plethora, and patient may also have diabetes also. So you check for the Cushing syndrome by using 24-hour urinary cortisol and late night salivary cortisol and low dose dexamethasone suppression. These are the biochemical discriminatory factor, and there are certain clinical discriminatory factor which increases the chances of Cushing syndrome to be present. And Cushing syndrome, after diagnosing Cushing syndrome, you have to check for the origin of the etiology. This is primary Cushing or secondary Cushing by using certain investigation like high dose dexamethasone test and petrosal blood sampling for ACTH secretion. So in a nutshell, you suspect a patient with hypertension, first check the blood pressure accurately and repeat the office reading. If the patient is having only hypertension in the office reading, then look for the out of office reading by using ambulatory blood pressure monitoring. And patient may have normotensive and white coat hypertension. You no need to treat those patient, you just monitor them, and counseling is the best part. And if the patient is having confirmed hypertension, then check thorough history, examination, and screening laboratory tests, which was previously I have described. And if there is features of secondary hypertension, then you have to go through the certain investigation, and if no, then you just check for the hypertension monitoring and treat accordingly, as this is the essential hypertension. If the patient has secondary hypertension feature, then you have to check for the causes of secondary hypertension. If the screening suggesting a specific cause, then you have to treat the specific cause. The patient may ultimately cure from the hypertension, and he or she may not require antihypertensive in future. So if the screening tests are not suggesting a specific cause, then consider more aggressive evaluation for secondary hypertension. This is all about approach. And now let's discuss certain guideline on hypertension. We know that the JNC 8 guideline is present on 2018, and let's discuss our target of blood pressure. So if the patient's age is less than 60 years, then our target is 140/90. If more than 60 years, then we can consider a higher blood pressure range like 150/90. And if CKD and diabetes is present, then we also have to look for the hypertension monitoring according to CKD and more than less than 60 years, and diabetes and more than 60 years. Targets are almost same. And if therapy we have to give in case of non-black patient, we have to give thiazide AC or ARB. If the patient is black African origin, then thiazide CCB is the first choice, and if CKD is present, AC ARB first choice. And make sure that patient patient is taking monitor regularly, because AC and ARB has a higher chances of hyperkalemia and CKD also, which may cause sudden cardiac deterioration. And other points: do not combine ACB and ARV, because both are acting through the same pathway, RAS activation system, inhibition of RAS system. Beta blocker are not the first line therapy in any points except the cardiac causes like post MI patient. Assess the treatment effect monthly until the goal of BP is reached. Call the patient in every month and check for blood pressure. If the blood pressure is okay, then goodbye the patient, it's okay. And if the blood pressure is higher, then you should titrate the dose, increase the dose, or add another class of the antihypertensive drug. And this is 2070 ACC guideline. Here, for elevated blood pressure, non-pharmacological intervention you should take first, like DASH diet, reducing sodium intake and potassium supplementation should given, increase physical activity, limiting alcohol consumption, and losing body weight for those who are overweight. And pharmacological treatment should be given only stage 1 and stage 2 hypertension, or and increase cardiovascular risk. ASCVD risk is more than 10%. You can calculate ASCVD risk also. Here is the schematic diagram of DASH diet. You should take low fat. Fat and sweet should be limited. Fresh fruit and vegetables should be taken. Grains, leans, protein, and legumes should be taken. Blood pressure treatment and threshold for high blood pressure, as we have discussed. If the patient is adult with confirmed high blood pressure, no CVD and 10 years risk, then blood pressure medication should be recommended if more than 140/90. Adult with clinical CVD and start medication if only 130/80. A target blood pressure should be closer to 120/80 mmHg is generally better than the higher BP target like 150/90 or etc. Selection of antihypertensive: if patient black and elderly patient, start with thiazide, but the problem is hyperuricemia and hyponatremia. So in black and elderly patient, you can also start with CCB. So here CCB should be non-dihydropyridine group of CCB. And in case of heart failure, post-MI patient, diabetes mellitus with proteinuria, or in proteinuria patient with hypertension, start with ACE and ARB. Here the problem is hyperkalemia and pregnancy is the contraindication of ACE and ARB. And beta blocker should be given in post-MI heart failure and angina patient. So problem with beta blocker is COPD and peripheral arterial disease. So thank you everyone.